I was saying, this is the duro, and it's important to know where it's exactly located because two major types of bleeding is happening here, or in relation to this structure, which are the epidural and subdural hemorrhage. And here is another presentation of the brain or skull, where we can see the skull, dural, arachnoid, via mater, and brain tissues. So when we are talking about traumatic intracranial hemorrhage and spontaneous intracranial hemorrhage, they are two different things, but most of the epidural and subdural hematoma are usually traumatic, while intraparenchymal hemorrhage or the ICH and subarachnoid can be related to another pathological malformation. For example, subarachnoid usually will happen in relation to aneurysms, AVMs, and rarely traumatic subarachnoid hemorrhage. While the ICH will be happening usually with hypertensive patients, and it will have certain specific location. I often during my presentation I talk about things very, very briefly, but if you guys have any questions, let me know. So here is another picture of the types of intracranial hemorrhage: epidural hemorrhage, subdural hemorrhage. Usually epidural, there is, I think you guys passed by the table which differentiate epidural and subdural hemorrhage. Epidural is usually less shape, it doesn't cross sutures, and it's like almost more than 90% will be in traumatic patients and will be associated with fractures, while subdural can happen at extreme ages, and it's more common in elderly and can happen after repetitive fall. Intracerebral hemorrhage can be related to like hypertension patients, or can be a contusion from trauma that expands to an ICH, but usually it will be associated with another kind of bleeding. And the other thing related to intracerebral hemorrhage, it can be like part of a tumor, like tumor itself is bleeding within itself. And sometimes the AVMs can cause the small ICH, but not necessarily subarachnoid hemorrhage. Here, I don't think this is really accurate about subarachnoid hemorrhage. Subarachnoid hemorrhage usually diffuse and come in star shape. But they just like this. Here are different kinds of bleeding that can happen with different reasons. Like for example, here tumor metastasis, some kind of brain metastasis will be presenting as an ICH or focal hyperdensity. Infarction, sometimes the stroke will be having hemorrhagic transformation. And here is also an AVM where it can be presented with ICH. So usually it's a very common clinical or real life scenario actually when a young patient is coming without clear reason of ICH, like someone who's suddenly collapsing with loss of consciousness. Although like there are guidelines when to evacuate ICH and so on, but you always have to be careful and go with CTA, CCRG to make sure there is no underlying vascular malformation like an AVM for evacuating the ICH. Because if you did so, you may cause major bleeding that you can't control. Like if you just aim for evacuating the ICH and there is underlying vascular malformation. Regarding the symptoms of intracranial hemorrhage, like any neurological pathology or intracranial pathology, it's actually very variable and related to the context of the pathology, like fracture with epidural hematoma will be different than subdural hematoma in an elderly guy, and different than ICH that happen to a hypertensive patient. However, the common symptoms are sudden severe headache, weakness or numbness. It depends on the location. Bleeding, patient will have weakness or numbness, and sometimes aphasia, dysarthria, difficulty speaking or understanding speech, loss of coordination or balance, nausea or vomiting. And sometimes patients will have more severe presentation, like they will have increased ICB and they can present to you in very bad shape, like they will have severe headache, they will have hypertension, which is the Cushing triad, they will be confused, and sometimes they will come with low GCS or anisocoria, even like unequal fusion. Again, here are the types of traumatic hematoma. like subdural hematoma, epidural hematomas, and the intracerebral hematoma, and confusions. Depends on the mechanism of injury, basically. So the first thing is the epidural hematoma, which occurs when the blood accumulates between the skull and the dura mater, which is the thick membrane that's covering the brain. It's variable. The incidence of epidural hematoma is variable, ranging from as low as 14% and up to 35%. And it can be fatal, especially if it wasn't recognized quickly. There is one specific presentation of the epidural hematoma, which is the lucid interval, where patients initially have severe headache or something, and then he improves completely, and then all of a sudden he collapses. And this is related to the pathophysiology of the epidural hematoma itself. So it's very common that patients will be missed while they are having the lucid interval, that they don't even get proper investigation. And unfortunately, they present later at very late stage for any intervention. Uh, as we mentioned earlier, epidural hematoma is always almost associated with skull fracture. It's an impact-based phenomenon, like you have to have a direct contact or cause an epidural hematoma. Uh, not only small head motion or inertial effect can just cause epidural hematoma. Usually it will occur during the fracture initiation or propagation period, and it will be related to the underlying dural membrane being teared with the underlying vessel, which will fill the epidural space. In very rare situations, it can occur spontaneously in patients with underlying vascular anomalies or like infection. So the common artery to be injured in epidural hematoma is the meningeal artery. There are different types of presentation of epidural hematoma radiographically. Like it can be acute or hyperacute. And sometimes there will be something called swirl sign. Like in the case of when it's active bleeding. And the other type can be subacute, which is days 2 to 7. And the third one is chronic, which is 7 to 20 days. Here is different representation, like here is chronic. فاحنا نعرف إنه acute و hyperacute or subacute or chronic by the density. When it's like really white, it's hyperacute. And when it's almost the same color as the matter, it's subacute, and when it's darker, like here, it's chronic. And here they are trying to show us the fracture because as we agreed earlier, it will be always or almost always associated with underlying fracture. Treatment depends. Like epidural hematoma can be surgical, and with surgical, it's a life-saving surgery. Like you have to do it as soon as possible because the patient, otherwise, patient will herniate and may die in a very short period. Or you can go conservative. The indication for epidural hematoma surgical treatment is depending on the volume, regardless of the GCS score. Like if the volume is more than 30 centimeter, and the patient GCS, even if it's more than 8, you should evacuate. If there is midline shift more than 5 millimeter, or if the thickness is more than 1.5 centimeter, and if there is a focal deficit or low GCS, less than 8, equal or less than. If the patients have good GCS and the volume and the deficit are volume and the thickness are good and can be observed uh, clinically, you can go with non-operative management. However, it needs to be under close neurological observation, and you have to follow the repeat CT scan. The first repeat CT scan usually occurs within 6 to 8 hours because this is the most common period of the bleeding to expand. And after that, you can follow like in 2 or 3 days, and if the patient is well, we can discharge him and just follow him in the clinic and give him the red flag. Uh, this is for epidural hematoma. For subdural hematoma, it usually forms because of an accumulation of blood and the epidural matter. It's more common in extreme ages, like kids or adults, elderly, basically, because their brain is with low volume, so it's easy for the dural bridging veins to be lacerated and to rupture and cause subdural bleed. Presentation will be more or less the same as the epidural hematoma. However, the symptoms will be occurring in more prolonged period. Sorry, I think it was disconnected. The common scenario for subdural hematoma is an elderly man or elderly lady who fell multiple times, and you will find like long history of
Doctor?
yes.
Yeah, we lost the connection for the screen share. We
So
cannot see the screen.
I think that- Can you see now?
Yeah, it's yep, now we can see it.
Okay. So the common scenario for subdural hematoma is usually elderly population, where they have initial fall and the patient was fine, and then taken to the hospital, and then a second, third fall. Then patient will present with either weakness, numbness, or confusion. And you will do CT and you will find different types of subdural hematoma. Like sometimes you will find like this homogeneous subdural hematoma. Uh, this tells you that it has been there for quite some time. However, this is large and usually indicates surgical intervention. But subdural hematoma is not as acute as the epidural hematoma usually. Also, it can be laminar, like where hematoma has density layer along the inner hematoma membrane, or separated, where hematoma is having two components of different densities with a clear margin lying between them, or trabecular, like this one. Like you feel there are some internal septum within the hematoma. And as we learned, the epidural hematoma, it can be acute, subacute, or chronic. طبعا subdural hematoma, this is extremely brief talk about subdural hematoma. But in reality, there is acute subdural hematoma, there is chronic subdural hematoma, and they are managed surgically different. Like in chronic subdural hematoma can be in one side, and sometimes can be bilateral, like the two hemispheres. And there are different types of modality of treatment, that you can do verhole evacuation or mini craniotomy. And there is even interventional radiology management where you do the middle meningeal artery embolization. And there are some medical trials like dexamethasone and antihypertensive medications that are being treated, being experienced for the treatment of subdural hematoma. Especially subdural hematoma has a bad tendency to reoccur or recollect. So that's why they are trying to treat different kind of, trying to like explore different kinds of treatment. So if there is traumatic brain injury, there are different guidelines of the indication, but the commonly agreed one for subdural hematoma, if it's more than 10 millimeter thickness, GCS less than 9 or 8 with neurological deterioration or more than 5 millimeter midline shift. Now we will go for the ICH. So intraparenchymal hemorrhage or intracranial hemorrhage is one form of intracranial bleed where the bleeding is within the parenchyma. It occurs in up to 20% of strokes. And the 30-day mortality can reach up to 50%. And there is like a mortality score for ICH if you guys want to check it, which guides you for surgical intervention and when to operate the patient and give you hints about the prognosis or the expected prognosis of the patient. So there has been some proposal of genetic association, and it's still under exploration. So the causes can be related to hypertension in most cases, and sometimes lipohydrosis, where the intraparenchymal arteries are having irregular fibrosis and failing deposition. Or if there is like this is specific kind of microaneurysm, which are called Charcot Bouchard aneurysm. Let me show you the picture. Um, it's also common question in neurosurgery. What kind of aneurysm can cause you ICH? It's this one, the Charcot Bouchard aneurysm. It will cause ICH in some rare cases. And then classification can be primary or secondary ICH. The primary is the most commonly secondary to hypertension or cerebral amyloid angiopathy in patients with long-standing diabetes. Or secondary ICH, like patient is having vascular malformation, coagulopathies, and head trauma or transformation from infarction to hemorrhagic infarction. This is what I have here written in the slide. What I would give you as highlights in like daily practice or clinical practice. When you are approaching the neurosurgical patients in general, you have to classify how urgent is the patient. Is he really urgent and I have to like now, or patient can wait, and for how long he can wait? So if you are being like, for example, on call, uh, and you receive a call, you have to understand what is the vitals of the patient, like go always ABC, and the scenario and the medical background. So like head trauma patients, if they are coming with low GCS, I would be always vigilant and cautious not to miss the diagnosis that we can help on, like epidural hematoma or subdural hematoma, because usually when you evacuate the patient in the right time, you will save life actually. You will find the patient doing well within 2 3 days. However, if you miss the time period where you can interfere, patient can deteriorate very quickly, and even if you interfere surgically later, it won't be of great help. Always do your appropriate neurological assessment, including pupils assessment, because if the patient is having unequal pupil, this is a very alarming sign and indicates an urgent need for surgical intervention. And also, if there is like unexpected delays in surgeries, you can start always the management of high ICV, the medical or conservative management of high ICV, like head elevation, dexamethasone, mannitol, hypersonic saline. All of these things can give you sometimes and can help in relieving the pressure. Because high ICB will cause herniation, and herniation syndrome is something really another topic, but if patient is herniating, usually it's really hard to reverse. It's almost impossible. And do the appropriate investigation. Like, for example, sometimes you will find a large epidural hematoma and you will be excited to operate or something like this, but then you find the patient having abdominal coagulation profile, and he's known to have some kind of coagulopathy and multiple treatments. If you are not taking patients, طبعا it's a top emergency case, you have to take your weapons with you, like reverse whatever coagulation he is taking and get push cause plasma, prothrombin, complex concentrate, and whatever that can aid you in the OR. But if you have sometimes like a subdural hematoma, it's usually not super urgent and doesn't need to be operated in timely manner. Optimize the patient condition. like make sure that the coagulation profile is good. There is no underlying vascular malformation, and that your surgery will be actually of benefit, not the other way around the patient. And I think this is all what I have. If you guys have question or something, please let me know.
Doctor, I have a question. Yes, Allah dook. So, regarding the brain herniation, after surgery, will the patient be able to regain his full function and the same
Can you-
as before?
From your
It's
goal
impossible.
is to operate before the patient is herniated, because if the patient is herniating, it's actually too late. Most of the time, patient will not recover completely, but if you catch him at the right time, yeah, he can regain function completely. Especially in the cases of the neurohematoma. So neurohematoma, if it's traumatic, yes, but if it's acute or chronic, patient often will come to you initially with later presentation. The moment he comes to you, and then the patient, he already told multiple times, his medical condition is bad, his condition is not good. So you wouldn't really do much changing his clinical condition.
Okay, يعطيك العافية دكتورة. Anyone wants to ask?
ما في أسئلة.
في سؤال بالchat. Besides hemorrhage volume and neurosurgical status as indications to go for surgery in hypertension, ICH, does the age play a role?
Yes, it always play a role, especially in ICH cases. Because most of the ICH cases, it will be related to hypertension, and there are a lot of trials when to operate ICH, like attached to trial, for example. Age is major يعني factor to decide. Like most of the trials, I think they are reaching to age 60 or 70 as a cut limit. You can check the ICH score, which will to help you regarding the surgical decision and the expected prognosis of the patient. Because if the prognosis is poor due to the general condition, you are just starting يعني extra burden for the patient by exposing him to the surgery that won't help him much. Does this answer your question?
طيب دكتورة يعطيك العافية. The session was very helpful. I think with this we can conclude the session if no one wants to ask يعني.
يعافيكم. معليش أنا توقعت إنه الساعة صراحة فاخذت كثير مرة.